This is a lecture that's going to be talking about arterial peripheral, atherosclerotic peripheral arterial disease, sometimes just referred to as APAD. I know you can't see the screen behind me, but just listen to my voice, even though my voice is kind of going too. I'm sick at the moment. So, first of all, what is it that well, I guess I should say, what is this exactly? So, you get your peripheral arteries, you have an atherosclerotic plaque, and it is pinching down on the diameter, and it's making it more difficult for blood to get through. But typically in your peripheral arteries. So what's the cause? Just went over that. Risk factors. So it's a lot of the same thing as it would be for congestive heart disease. Your age is a big factor. Older people get it more often. Smokers get it more often. More common people with diabetes. More common people in hypertension, dyslipidemia, or if they have higher levels of C-reactive protein, or if they have increased levels of serum homocysteine. What is a clinical presentation? Usually it's going to be they're going to have some like random pain, like a claudication, intermittent claudication, which is like cramping, aching pain, numbness, that sort of thing, during exercise. So they'll be exercising, doing something, and all of a sudden some part of their body will hurt or ache or cramp. And then when they stop exercising, it goes away again. So on physical findings, when they come in for the physical, what you're going to find is when you take their pulses distal to the APAD, you're going to find, or the obstruction, you're going to find that the pulse is going to be decreased, or maybe even gone completely. And if you listen over the bruits, over the blood vessels that are narrowed, you're going to hear bruits, which is a certain sound that you can look up online. And also the person may have muscle atrophy, which makes sense. The muscle's getting less blood, it's going to undergo atrophy. The prognosis, it's going to closely coincide with congestive heart disease, CHD, which I'm assuming means congestive heart disease. 15 to 30% is the 5-year mortality rate on that. The proper screening for this includes giving a good history, asking of the smoking, other kinds of things like that. Then check the pulse in both ankles, and if one of them is below a 0.9 ratio, then that is indicative of APAD. Also, you can give them a duplex ultrasound, so you can kind of see where the blood vessel may be thinning through the ultrasound. As well as a transcutaneous oximetry, which is basically testing the oxygen in the blood, in the tissue. Also, you can do a stress test, and you can also do CT angiography. But for that, you have to give them the fluids with the CT and everything, so it shows up on the scanner. And sometimes that's dangerous if the person has some sort of renal impairment or something, so you got to be careful with that. And also, an MRI can be contraindicated if some of the things are pretty serious, like with the kidney and whatnot as well. So, for therapy, chronic therapy for these people, give them ACE inhibitors. ACE inhibitors are going to be something that are going to help them to lose some of their high blood pressure. You give them statins. Statins are the HMG-CoA reductase inhibitors. So they're going to basically help people to decrease their LDL and increase their HDL. Encourage them to stop smoking. You can give them aspirin without clopidogrel. I don't know how to say that word exactly. Aspirin's a COX inhibitor. So this is going to help their platelets to not adhere. Prevent thrombus. You can also give them silostazol. I've never heard of this before, but apparently it's a phosphodiesterase inhibitor as well as a vasodilator and has antiplatelet properties. And if it gets really serious, you can give them an angiography, which means blood vessel surgery. And if it's really, really serious, you might have to give them an angioplasty. Sometimes you can also encourage them to undergo supervised exercise. Insurance isn't going to pay for that, but also it isn't really going to help the disease, but it might increase their ability to walk longer and be able to do more things. Also, regarding these the arterial bypass or the angioplasty, kind of comparing the two. In the case of an angioplasty, basically what this is it's a stent. It's usually done in the iliac artery or the femoral or popliteal artery. And if you're going to do an arterial bypass, this is usually going to be the aortobifemoral artery or the axillofemoral, or a femoral to femoral bypass. Could also be a femoral popliteal saphenous bypass. And that's the first part of this disease.